Hi, everyone. Today we will be presenting on point of care lung ultrasound in detecting pneumonia. My name is Dr. Stephanie McMillan. I am a third-year resident here at USF Internal Medicine. And alongside me in making this presentation is Dr. Andres Cordoba, Dr. Kevin Chow, Dr. Kieran Kaur, and Dr. Lisa Cochran. Today, our learning objectives will be understanding how a lung ultrasound is performed, how to comprehend the basic physics concepts of lung ultrasound and recognize the most common artifacts, how to recognize the various lung ultrasound findings seen with pneumonia, and to list the advantages and disadvantages of using ultrasound to evaluate the lungs and compare this to other imaging modalities.
Hi everyone, this is Kevin Chow. I just wanted to throw out a clinical scenario in which we might all be using ultrasound. So we have a 48-year-old patient who comes to the internal medicine clinic or acute care visit with cough and shortness of breath for the past 24 hours. He's not established with the clinic and he doesn't have any known medical history. On exam, his temperature is 100, his blood pressure is 100 over 60, his heart rate is 90, and his respiratory rate is 18. As you can kind of tell, these are all somewhat indeterminate for maybe he has something going on, but also maybe not. So maybe we can use POCUS and what we learn in the next couple slides here to determine how we should triage this patient and treat him.
So now we'll take a look at comparing lung ultrasound to chest X-ray. So there have been several meta-analyses as well as some studies done that are comparing lung ultrasound versus chest X-ray in diagnosing pneumonia, whether that's in the clinic setting, in the ICU setting, or in areas that have more limited resources. So the overwhelming majority of these studies found that there is a higher sensitivity and higher accuracy using lung ultrasound when compared to chest X-ray for diagnosing pneumonia. However, there were similar specificities between the two. Some advantages of using lung ultrasound over chest X-ray include that it's non-irradiating, it's fairly cost-effective, it's portable, and it's rapid, so you're getting real-time feedback while scanning these patients. Now, in ICU settings, this can be particularly beneficial and useful for patients with acute respiratory failure, as they might not be able to give us a great quality chest X-ray. It can be more difficult to perform if they're not able to properly aerate their lungs. There are some limitations when we're looking at ultrasound. This includes operator dependence and bias, so making sure that whoever is performing the ultrasound is using the proper techniques in finding those specific artifacts that are associated with pneumonia and that they're able to properly interpret these as well. When we come to look at ultrasound probe of choice for the lungs, there are three main choices of ultrasound probes, and truthfully, you could use all three. However, traditionally, most people are grabbing for that curvilinear transducer. This is our most common go-to probe for lung ultrasound due to the low frequency and the larger footprint. This ensures that you're not going to miss anything by doing a thorough scan throughout the lung. Now, the linear transducer has a higher frequency, and this can be best for examining the pleural space, and in particular, looking for that lung sliding and to make sure that there is no pneumothorax going on. You can also use the phased array transducer. This also has that low frequency, but it's a smaller footprint. It may be easy to miss localized pathology. However, this can be beneficial if you're looking at both the lungs and at a cardiac ultrasound. So how should we scan our lung fields when doing a thorough lung exam? Traditionally, we separate our lungs into 6 different fields. We have our anterior, superior, and inferior sections, our lateral superior and inferior sections, and then our posterior superior and inferior sections. You are using your probe of choice. In this case, we could use a curvilinear probe, and you want to make sure that you're scanning longitudinally and in a transverse orientation. When you start to scan through these different lung fields, you want to start in that anterior superior position, starting at the top in a longitudinal scan, and make sure that your probe indicator is pointing towards the patient's head. You're going to start by sliding down through each rib space to make sure that you're not missing anything until you get to the liver. And then you're going to do this on the lateral ends as well. You'll do this on one side, and this can be with the patient laying flat. And then to scan through the posterior sections, you're going to have the patient sit upwards, and they can either relax their arms down or place their arms above their head so that you can get an improved view and do the same thing scanning through.
Hey everyone, this is Lisa Cochran. I'm going to talk about the physics of lung ultrasound. So the basic concept of ultrasound, just as a reminder, the ultrasound probe will emit sound waves which bounce off different tissues in different ways based on that tissue's impedance. And impedance is just a measure of how well the sound waves travel through certain substances. And it's a number that's directly related to the tissue's density. So as a tissue gets more dense, the impedance increases, so the sound is able to travel through better through denser tissue. And then the waves bounce off, the probe detects those reflected waves and creates an image on the screen. An artifact that is very relevant in lung ultrasound is reflection. So reflection occurs when there's large differences in impedance between two tissues. So it's not necessarily the impedance of a tissue that creates reflection, it's the difference when two tissues are adjacent to each other that will create a reflection. So an example in lung is when the soft tissue of the pleura is up against air-filled lung. And so the difference in the impedance will cause the reflection of a sound wave, and that's what creates A lines. A lines are the horizontal, echogenic, curvilinear lines that you see when you put your probe against normal aerated lung. And it's the reason, the reflection is the reason why air itself cannot be directly visualized on ultrasound, and it's because the waves are just reflected back onto the probe. So we learned about what normal lung will look like on the probe. You'll see A lines, but what if there is fluid or a substance of higher density than air within the lung instead of air? And that's when you get B lines. So this brings us to another artifact that you see a lot on lung ultrasound, which is the reverberation artifact. And this is created when the sound waves bounce between particles of increased density. The way that I like to think about it is if you look at the middle picture, the probe is emitting sound waves onto particles of fluid that are surrounded by air, and the waves kind of bounce between the air bubbles down through the fluid. So if you think of it like one of these games, the disc drop or like a ball drop game where it kind of bounces between those pegs, that's what creates that vertical hyperechoic line that we have named B lines. And so we'll talk a little bit about what that means on the next slide. So these are kind of the findings that you'll see in early pneumonia. So going back to A lines, you actually will not see, it'll be an absence of A lines if there's an early pneumonia developing, and then you'll see B lines. And then it's important to distinguish if the B lines are diffuse or if they're focal. So diffuse B lines can mean interstitial fluid, which could indicate an atypical or viral infection within the lungs. It can also indicate pulmonary edema. It can be a sign of ARDS. So the differential is pretty wide. And then focal B lines, so you'll only see B lines in like one spot or one lobar area. And this can indicate a consolidation, which could be a sign of lobar pneumonia. Also, a lung contusion can cause this in the setting of trauma, focal atelectasis, and other things like that. So the differential is wide for both diffuse and focal B lines. And then for early pneumonia, you may or may not see sliding of the pleura. If you don't see sliding of the pleura, this could indicate a pleural effusion, which we'll talk more about later. And then important to note, just because you see sliding of the pleura, it does not rule out a pneumonia. So you can still have pneumonia with sliding. You can also see tiny areas of subpleural consolidation with pneumonia, but important to note that these are not specific for pneumonia, and usually they're seen with the other findings that we talked about, so the B lines and the absence of A lines. When you see subpleural consolidations by themselves with no other findings, this is actually more specific for a pulmonary embolism rather than a pneumonia.
Hi, everyone. This is Andres Cordoba. So now we'll be focusing on a couple important ultrasound findings seen in pneumonia. First is the shred sign. Shred sign refers to an irregular, shredded-looking border. In pneumonia, infection causes alveoli to fill with fluid and other inflammatory material. This creates an uneven interface between the normal aerated lung and consolidated lung tissue. And this can be seen on the right-hand picture depicted by the black arrows. However, I will say subpleural consolidations can be seen in other etiologies like PE. So it's important to always keep in mind the clinical picture and the patient presentation. Next sign is hepatization. Hepatization refers to the lung tissue appearing similar to liver tissue on ultrasound, and this refers to the echogenicity of the picture. This really represents a more advanced pneumonia or progression of pneumonia with dense consolidation formation. Often we see hepatization with air bronchograms, as we can see in the picture here, highlighted by these hyperechoic vessel-like structures. Hepatization reflects some complete loss of air, so it's important to keep in mind that it could also be seen in atelectasis. However, certain features favoring pneumonia versus atelectasis include a dynamic air bronchograms and increased blood flow on ultrasound, and we'll go over these in future slides.
So talking about those air bronchograms, I have two examples of those here. On the left side, we have dynamic air bronchograms. The white that we see filling in with respiratory variation is the air actually coming into the bronchi, showing that air movement is occurring here. And the reason that we're able to see it so well as opposed to normal lung tissue is just because of the consolidation of alveoli. As we mentioned, because we can see that the air is moving, it's more likely that the consolidation of the alveoli is more due to like a pneumonia-like process versus atelectasis. On the right side, we have the static air bronchograms, which don't really change as much with air movement and respiration. The stasis of that air is a little bit more indicative of atelectasis or alveolar collapse, where the air is just trapped there and not moving with respiration. You can also see a pleural effusion is present on the right side here, and that is moving with respiratory variation.
So the use of color Doppler is really helpful in lung ultrasound when you want to differentiate a lung abscess from an empyema, because they can look very similar on just plain B mode. So a lung abscess, if you throw the color Doppler on it, it will have blood flow markings surrounding the abscess because it has vascular lung tissue around it because it's actually within the lung, whereas an empyema will not have the surrounding vascular flow around it. And studies have found that it's actually the most accurate way to differentiate the two.
Hi everyone, my name is Kaur. Here we're going to be talking about parapneumonic effusions versus empyema. And this is where lung ultrasound really can become clinically important as well. Just for review, a parapneumonic effusion, it's typically pleural fluid that develops in the setting of pneumonia. These can be either simple or complex, versus an empyema normally represents infected pleural fluid, and this typically is managed with drainage and antibiotics. On ultrasound, a simple parapneumonic effusion typically appears anechoic, meaning completely black, and there's no internal echoes or septations. A complex parapneumonic effusion falls in between the simple effusion and empyema, On ultrasound, this may appear more echogenic or have internal debris or early septations, but it may not yet represent frank pus. Clinically, these effusions are important because they're more likely to progress and they often require a little bit closer monitoring. When you start to see marked complexity, including thick septations, loculations, pleural thickening, or dense internal echoes, this starts to raise a strong concern for an empyema. The definitive distinction between a complicated pneumonic effusion versus empyema typically relies on pleural fluid analysis via a thoracentesis, which also an ultrasound helps facilitate. Additionally, lung sliding is typically absent as the fluid prevents the visceral and parietal pleura from sliding. The key clinical point here is that ultrasound typically helps stratify risk. So simple effusions can often be managed with antibiotics alone versus pneumonic effusions and empyema need closer follow-up, might need antibiotics plus drainage.
We also just wanted to mention viral pneumonia here in the context of POCUS. The video is unfortunately maybe not going to be playing, but you can see that the slides following. What you might find is subpleural consolidations, so that hypoechoic space right on that pleural line there at 12 o'clock. Also just any kind of irregular thickening of that pleural line where you normally see a nice sliding effect right on that pleural line. It might have a little bit of chunkiness on there that's not seen in normal lung tissue. You're also maybe finding some air bronchograms, which maybe you can see in that bottom part there, which would be better visualized on a video. And some focal B lines, more evident and focal on that part where you're having the pleural thickening and subpleural consolidations. As you can see on this chart here, there's more emerging research kind of delineating between the type of specific viral etiologies of viral pneumonia that may or may not have more findings. But the key differences are you're less likely to have your characteristic shred sign or hepatization. Might look a little bit more like normal lung, but with some of these extra findings.
Just going to go over some pros versus cons of POCUS. On the left are advantages of POCUS. It's fast. It can be done at bedside, gives us real-time information without any radiation. It can also be repeated as often as needed, and it improves both diagnostic accuracy and procedural safety. On the right are some limitations. POCUS is very operator dependent, can have a limited field of view, and image quality can be poor in certain patients. Additionally, a negative scan doesn't always rule out disease. Artifacts can be misinterpreted, and it doesn't replace formal imaging with CT or MRI. And these are our reference slides.